edition of Climax After Dark, our first edition. Welcome to our show tonight. We have a wonderful guest to help us navigate through fact versus fiction of PCOS and intimacy, Dr. Basma Faris. She is a dear, dear friend of mine, an expert in the field, and also someone who's making inroads and innovations in PCOS and the care for PCOS. Dr. Faris, thank you so much for joining us.
Hi, everybody. Thank you, Dr. Ojo Cairns. I am so honored to be your inaugural guest.
Yes.
This is so fantastic. I'm so excited about everything that you're doing, and I'm so happy that you asked me to come and talk about this really important topic. And I think it's a great segue for us to really, put um, our minds and our expertise together and really share with the folks out there the importance of talking about PCOS, the importance of talking about intimacy.
Mm-hmm.
And so I'm really excited to get into it.
I'm excited for you to be here too, because not just because, I love you and I love everything that you do, but PCOS is something that affects many women. And because it affects women, physically, it's also going to affect them with their intimacy too. It's going to impact their partners and their relationships. And so this is a side of PCOS that women are impacted by, but we don't talk about it enough. We don't talk about PCOS enough, but we definitely don't talk about this part of PCOS and how it impacts intimacy enough. So I think it's going to be an interesting topic. I hope you have your wine ready.
So I got my bubbly. I have a bubbly of a different kind. Cheers.
Yes, cheers to you. Cheers to you after a long day of work.
Mm-hmm.
Let's enjoy ourselves, unwind, and first talk a little bit about PCOS and specifics. What is PCOS and how common is it?
So PCOS stands for polycystic ovarian syndrome, which is actually a terrible name for the condition, but it is a endocrine or hormonal disorder that is complex, that has a multitude of different causes or underlying factors and affects multiple organ systems. So it affects the reproductive system by means of affecting ovulation and therefore fertility, and therefore also affects your menstrual cycle. It affects the dermatologic system. So people may suffer from acne or facial hair growth or alopecia, which is hair loss.
Mm-hmm.
So women and other people who have polycystic ovarian syndrome can suffer from anxiety and depression more than their counterparts without PCOS, and there are also increased health risks. So people with PCOS are at increased risk for cardiovascular disease and diabetes and certain types of cancer as well. So it's really important that we're approaching this as the chronic complex medical condition that it is, as opposed to maybe a more traditional approach, which is managing each of the symptoms.
And how common would you say it is? Some of the signs and symptoms of PCOS that you went over. Hair growth is something, and facial hair growth specifically is something that many that have the syndrome deal with. Some that have the syndrome don't deal with it.
Correct.
But there are also people that don't have, like I said, that don't have PCOS or have any issues hormonally, may have excessive facial hair, right? So I oftentimes hear the question, if I have hair growth on my face or excessive hair other parts of my body, does that mean I have PCOS?
Not necessarily. So in order to make the diagnosis of PCOS, the standard now is to use the Rotterdam criteria. And this requires that you to have 2 out of 3 of the criteria met in order to be diagnosed with polycystic ovarian syndrome. So evidence of elevated androgens, either by symptom, and that would be having facial hair or having cystic acne, or by having a blood test that shows you have elevated testosterone or one of the other androgens, is one criteria. Having ovulation dysfunction, which is either having very long menstrual cycles, so like up to 35 days is considered normal. More than 35 days, you want to be thinking about, is there an ovulation dysfunction? And also having a particular appearance on the ultrasound of multiple small unruptured follicles. And
Mhm.
follicles are the little tiny cysts in your ovaries that contain your eggs, and that's where the name comes from. And so if you have 2 out of the 3 criteria, you meet the diagnosis of polycystic ovarian syndrome. So if all you have is facial hair or cystic acne, but you don't have any other, if you don't meet any of the other 2 criteria, then you don't have polycystic ovarian syndrome. Now, might you be predisposed? I think certainly there is a spectrum where some people may, for some period of time, have one symptom, and then something happens or something changes in their life. They're all of a sudden their sleep is disrupted. They have a big shift in their nutrition. They have a big stressor in their life. And now we have that second, right? Then something else happens and they meet that second criteria. So that sometimes happens, but sometimes people just have one isolated finding and they never, they don't meet they don't meet criteria for PCOS.
Mhm. So you talked about the elevated testosterone, the elevated androgens, and so this is where, to me, it gets like into the juice
Yeah,
for it relating to desire.
sure.
Um, we know that um, testosterone is needed for desire. It's your main hormone for desire, and so if I want to have a higher like libido drive, is it not helpful to have a little bit more testosterone?
So, it's been looked at, and there seems to be, and this is sort of getting a little bit ahead, but there seems to be what we call in statistics a U-shaped curve. So, for all
Mhm.
you lay people out there who are not really up on your statistics, what that means is for people with polycystic ovarian syndrome or maybe other hormonal imbalances, there appears to be a sweet spot. Okay, there's a sweet spot for how much testosterone you want, but at low levels, you may have lower desire and libido. And then also at too high levels, super physiologic levels, or levels that fall outside the normal range for women, you also may suffer from a decrease. So there is a place in the middle where you want to be. So it's not always the case of more is more.
Yeah, more is not always, better, right? Because then you have, like you were saying, those symptoms of having too much testosterone
Yep.
that you don't want.
That you don't want. And I think this gets into really the crux of our discussion. Um, you know, it's becoming a much more common condition. So I'm very happy we're talking about it, right? This affects about 12%, by current estimates, and that may be an underestimate because of delay in diagnosis. 12% of reproductive age women and people with ovaries. So that's millions of people in the United States that are affected with PCOS, and it's
Mhm.
growing. And but as you know, right, testosterone is only one piece of female sexuality,
Mhm.
right? It is, and desire or libido is only one piece
Mhm.
of sexuality. So when we're talking about female sexuality, and certainly it is more complex than male sexuality, I think, one of the measures, if you look in the literature, one of the measures or the main measures is something called the FSFI, and that's the Female Sexual Function Index, right?
Mhm.
And it's a survey that measures many different components of female sexuality. And that's really the gold standard that's used to assess it when we're studying this.
Mhm.
And I've done in preparation for this, I was like, let's really do a deep dive. And the findings are really, really fascinating. So, in the most recent, there were like 2 recent meta-analysis. So for people who are not, again, statisticians, a meta-analysis is when a group of researchers take a bunch of different studies and combine them together. So that way they're allowed to include many, many more participants because many of these studies are small. They may just have a few dozen or a few hundred participants. So
Mhm.
to really, really get an answer, they combine all of these studies together and analyze them. And so the 2 most recent meta-analyses that looked at FSFI scores, or female sexual function index scores, between, comparing women with PCOS and women without, I actually didn't find a significant difference. And that was very surprising to me. But you actually have to then take a little bit more of a deeper dive and look at the different studies, because um, different populations and different groups really experience this differently. And I think it really has to do with cultural norms and what people perceive to be important. And
Mhm.
so, a couple of examples are, there was a Greek study that compared people with PCOS compared to controls without, and they had, so that this index gives you a composite score, but it also breaks it down into the different components of sexuality, right? And so those are drive,
Mhm.
arousal,
Mhm.
lubrication,
Mhm.
orgasm, satisfaction, and presence or absence of pain. So
Mhm.
these are all the things that go into that score. And so it did find that in this, like, one study, that in the Greek study in particular, that these people with PCOS did have lower rates of satisfaction, lower rates of lubrication, lower rates of arousal and orgasm, right?
Mhm.
In the PCOS group compared to controls. And, you know, the one factor in this particular group that accounted for this change was whether the degree of ovulation dysfunction in this particular population. Okay. But then when you look just, a few countries over, in the German study, which was done like a year or two prior to this other one, they looked at people with PCOS and their FSFI scores, which were also low, but the lower score actually correlated with the degree of hirsutism or facial hair. So I think that really goes to speak to sort of the importance, right? There certainly may be some physiologic differences, but it also may be sort of what is more distressing
Yes.
in a certain population, and how does that relate to their body image confidence and sort of sexual confidence and sexual satisfaction based on what they deem to be important, or in terms of their own sexuality. So I think that's really important. And there are other examples, right? The looking at, there was an Iranian study also that saw a decrease, and this was looking at people who were seeking fertility treatment,
Mhm.
and the there was high levels of dysfunction in this population, which is not unusual, because anybody that is undergoing fertility treatment, we know that's a very challenging and stressful time. But for them, it correlated more also with hirsutism, but there were more rates of pain. So
Mhm.
it really, it's like each individual population. So if you look at this meta-analysis and they didn't see a difference, I think that really reflects like regional and cultural differences in their approach to what's important, when it comes to sex.
So
Does
and
that make
that
sense?
it makes complete sense, and that's right into line with the, second thing I wanted to ask you about confidence. I think if anything I'm hearing from these studies is that um, how you feel almost plays a larger, or in these studies, a larger role than what you're producing, like your status, the diagnosis itself. And if you want to take that back and let's take it to basic science, I always tell patients there's the hormones, your testosterone, your estrogen, that's kind of like your icing on the cake.
Yeah.
There's more baked in, there's more to the cake than the icing that needs to happen to have, a good outcome, to have a good cake. And if you look at anatomy, that's really important. How you present, how lubricated you are, how sensitive the area, is. But there's also overall well-being, and that's everything else. And that hormone cortisol will outplay everybody.
Yep.
And so cortisol is high, we know, in stressful events. That's also stress in how good do you feel on your day to day. So if you have a higher level of depression, because you have a presentation like excessive hair, like those
Hmm.
patients with hirsutism, and that makes you feel less confident. It's going to make you feel less sexy.
Yep.
If you feel less sexy, you're not going to have a higher level of satisfaction, so
Yeah.
because that's going to play a role in your mind, right? Um, Man, that's good.
Yeah. So I thought I thought it was really interesting and learned a lot, when I just sort of really took a deeper dive and looked at, because I don't want people to think that there isn't a difference. And I think those
Yeah,
meta-analyses are misleading,
yeah,
right? And
yeah.
so I think we have to really appreciate, yes, people do experience, decreases in their body image, right? With polycystic ovarian syndrome. Polycystic ovarian syndrome as a metabolic disease leads women to gain weight more easily, have more difficulty losing weight. And in this sort of like, body image obsessed society that we're in, that also leads to decreases, in confidence and body self-image, and that can also factor into people's sexual experience as well. And I didn't look at those studies in particular, but I know that they're out there as well. And so I really think it depends on, like I said, in a particular community, what is valued and how that's going to play into the experience.
Now, let me ask you, do you think age plays a role? Because if you think about it with PCOS, right, that is a disease process that should be occurring when you are actively like ovulatory,
Yep.
right? Okay.
The interesting thing about PCOS is that as uh, women and people with ovaries enter their 40s, right? So with age, the ovulatory dysfunction tends to improve as the egg number decreases.
Mhm.
And so women who maybe never really had a regular menstruation and never were, ovulating on time, all of a sudden start getting regular in the like those years leading up to the perimenopausal period. And then women with PCOS also tend to have a later menopause by a few years, which is interesting. So some people, along with that, those that all of a sudden the symptoms improve, the menstrual regularity improves, and some of the other symptoms improve along with it. And then just the wisdom of being a little bit older and more comfortable in your skin, some of
Mm.
that improves. Some of that improves with age.
Let me ask you, let's go back to body image. What are some suggestions, right, for patients and women, people with ovaries that have PCOS, or are exhibiting signs and symptoms of PCOS? They haven't had a diagnosis, but they
Mhm.
think, okay, maybe that's something I have. What are some things that can, if we're saying body image is so important for intimacy,
Mhm.
to help with libido, desire, orgasm, strength, what are some things that can be done to help that end? Because I think we have a conversation commonly on what are the medical things, and we're going to go into the nutrition
Yeah.
in a little bit, but what are the medical things you can do to help regulate your hormone, your numbers, your hormones. But
Yep.
what are some things you can do for body image?
So, number one, find somebody who can give you a diagnosis. I think having a diagnosis is important because it helps you to sort of understand, explain what's going on, and take the proper steps that are important for you to improve your health. Okay. But then, secondly, understand that it's not your fault, right? And there's a lot of, we as the medical community have done a lot of our patients with PCOS a disservice, oftentimes by blaming and shaming. So, in not, people are told, oh, you have PCOS, just go and lose weight and it will get
Mhm.
better, right? And that's really demonstrates a lack of understanding. But that also leads to a very terrible shame spiral. Like, I did this, I made myself sick. It leads to disordered eating because people are afraid because they think that they have done this to themselves. And that is really counterproductive. So taking the approach that this is a disease needs to be improved and the disease needs to be treated, and we need to improve the underlying metabolic processes that are occurring, and that may result in some desirable, losses in fat mass. don't like to use the term weight loss, because really what we're trying to, we want to maintain our lean mass and we want to decrease fat mass, but approaching that from a point of really of health and of improving the underlying metabolic processes, not that the weight, right? This misconception that the weight loss is what's driving everything, or the weight
Mhm.
is what's driving everything, and that the weight loss then is the key to improving improving the disease process, or improving, improving your PCOS. So I think we need to take a different approach, and I think that's why a lot of people don't get care or don't return for care, because they've just been shamed and they feel terrible. So I think some of it needs to come from us, the medical community, to make people just feel more comfortable. And then just, I think things have gotten better. We have a lot of role models now, women who are just showing you can be active and you can be healthy and you can be sexy in
Mhm.
all different body shapes and sizes. And I think that that's really incredible, because it's not something that I felt that I had when I was younger. And so I think, looking to these role models is really helpful.
And there are also a lot of role models, or a lot of celebrities who have come out and said that they have PCOS too,
Yep.
and are beautiful in their own right, and also would be deemed as, extremely sexy too. And so I think, to your point, having an understanding that you're not you're not alone, and
Hmm.
this should not define who you are sexually. This
Yes.
should not define who you how you feel, and how beautiful and attractive and desirable you are. I think that's ultimately really important. I know, for example, uh, Victoria Beckham has said she has PCOS,
Yep.
and she's gorgeous, and sexy in many regards. Many people would say so. And so I think, it comes again down to that overall well-being,
Yep.
that self-confidence, and that is the most enticing drug to make. That's the most enticing thing to increase libido, honestly, increase orgasm strength. Um, Knowing that you yourself have that confidence within, or having that confidence within, it doesn't do anything but increase your dopamine, increase your serotonin, oxytocin, all those things that you need to have a better desire and better orgasms, and helps to outplay that cortisol, right? If we're taking it back to biochemistry again.
Hmm.
So,
Yeah, and BB Rexa, she just was on the Jennifer Hudson show, sharing her PCOS diagnosis, and her, her weight struggle that went along with it, and her experience of being fat shamed, and she's very outspoken, and I think she's undoubtedly somebody who presents herself as really being, she's beautiful and
mhm,
sexy and all of those things. So I really commend her for coming out and being open about it and sharing, because I think that really helps people. Especially, there's so many people
mhm,
out there who, maybe they have family members who have experienced PCOS, but maybe they don't, or they don't have any friends who have experienced it. And so they definitely feel, isolation, or not necessarily felt understood, and oftentimes not feeling understood by male partners. So having it
mhm,
more in the news is important also, so that that the partners also understand what's going on.
mhm. You know what? Let's talk about partners for a second. Having a partner that looks at you and sees you for who you are, and desires you, and you don't feel like you have to be somebody else for them, that itself is sexy, right? That itself just
100%.
helps
Yeah.
build confidence.
Yeah.
So
So if you
I
don't
think,
have one
it's
of
important.
those, yeah.
Yeah, it's important. Be smart about who you bring around you, or who you put the situations you put yourself in, or the people that you put in your space. They should always be elevating. They should always elevate you. I have a lot of people that always ask about, like, management with food, and this is
Mhm.
where part of your specialty has is,
Yeah.
and you've crafted a space for yourself, with nutrition and gynecological care, specifically PCOS. Can you tell
Yeah.
us about your practice and
Yes.
also
So I am so excited. I just opened my practice, my telemedicine practice, and I'm seeing patients, and I'm super happy doing what I really want to be doing. A little background is that I started my career as a registered dietitian. So I have a undergraduate degree in nutrition from the University of California at Berkeley. I then went on to get my master's in nutrition and completed a dietetic internship. And I worked for several years as a registered dietitian before I became a physician. So I've been working with people with PCOS for a long, long time, even before becoming a doctor. And when I became a gynecologist, I would see many of my patients struggling with PCOS and not really having, access to dietitians or nutritionists. So I would just do it myself, So I would do it all. I do the diagnosis, the medical management, the counseling. And it just like I find so much satisfaction because I really feel like it's something that I can offer to my patients that they maybe don't have access to elsewhere. And I just really find the topic very interesting because I really appreciate the power of nutrition and the power of understanding the science of nutrition and
Mhm.
metabolism to really to help and to translate that into real food, into not just a one size fits all prescription, a one size fits all plan, a one size fits all supplement. And so I really get to use like my very broad skill set to help people in a very specific way. And there's like nothing more satisfying to me, honestly. And I still love the other part of my job, which is delivering babies in the hospital, but this is something that just particularly brings me joy, and so I'm glad that I'm finally able to do that. So back to my practice, which is it's called PollyPrep MD, and Polly like the girl's name Polly, but also play on words because it's polycystic ovarian syndrome, and prep because I really want the experience in my practice to be one that is educational. So it's like a prep school because I really see my role, not, in addition to being a diagnostician, as an educator, right? And
Mhm.
so much of what I do is educating people on their disease process, educating people on their health risks and how they're going to get to a place of better health. And that I find is so empowering for people when they know, because if you don't, and having my own personal like health experiences where I didn't necessarily understand what was going on with my body, and there have been times that I haven't always been the best quote unquote patient or compliant patient, and it really came from a place of not understanding, right? So when we tell people, when we call people non-compliant, it's usually just because they haven't been like we've not done a good job of
Mhm.
explaining to them what it is and why. And so that's really what I see my role as an educator, and it makes me really happy. So I've created this small telemedicine practice, and right now I'm seeing patients who are people who live in New York and Florida only, but hopefully that will grow in time. And you can see me, and I spend a lot of time, getting into the history, reviewing all the labs, doing, if there were holes in the lab work or diagnosis, making sure that we get all the information that we need, and then really coming up with a patient-centered plan that we make together, right? That's going to center around very largely on nutrition, use of medication when needed,
Mhm.
and other factors like sleep is incredibly important, exercise, stress management, all of those things. Um, and and so that's what I'm doing, and I'm super happy, and I think my patients are too. And I, so if you're out there and you're in New York or Florida and you've experienced frustration because you feel like you're just not getting the information, or you're seeing your doctor, and you may like your doctor, but your doctor just doesn't have the time to really spend with you to get into it. Then please come and see me, because I promise you I'll spend like all the time you need. The first session is, we take an hour. to really, get into it. And so, because I really feel like that's the only way to do it. When I was in my private practice, I would have these 15-minute sessions, like, we touched like on one thing. Like it was really hard to affect any kind of real meaningful change if all I had was, 15 minutes with you. So
The 15-minute visit is a disservice to everybody. It
yeah,
really is. And it's unfortunately because of insurance. I'm gonna call it out. Because of insurance, something that we as physicians and healthcare providers are relegated to in the office. But when you are in positions like we are, where we've taken that leap to actually hold space for our passions, we're able to spend more time and really get into the nitty gritty
yep,
and help figure out what is the actual issue and problem and make a diagnosis plan that is patient specific, client specific. You said earlier um, that it's not just weight loss for PCOS. Oh, go lose about 10 pounds or 5 pounds and you'll be better. It's not just weight loss. We're looking at something more specific. And it's not just caloric intake. We're looking at something more specific as far as nutrition goes and also like fat mass and how the interplay with that and the hormone levels
correct.
that propagates the disease process. So I think, yeah, being able to have more time is great, but also have a higher level of expertise because that's what more time actually gives you. We only touch surface of PCOS today because we can go even deeper.
Yeah.
And we even just touch surface of intimacy today. We can go even deeper in that. You mentioned something earlier about the FSI scale with women PCOS and how vaginal dryness was more.
Hmm.
Okay. Vaginal dryness itself is going to decrease your level of climax.
Yep.
It's going to
Yeah.
decrease your level of desire. It's going to decrease your level of satisfaction automatically, and that's just it
Automatically.
itself.
Yep.
So, what can you do for your dryness if you have PCOS and you're managing and you're managing the PCOS? What can you do to augment and increase your vaginal lubrication? That's also going to help. So, having these like more comprehensive discussions and looking at it from that level of detail just helps. It helps a lot. Everyone should use good lube.
Yeah.
That's first.
100%.
There's
100%.
a lot of crap in the store. There's a lot of good stuff out there, but there's a lot of crap that people use. Beloved, I don't know if you've seen any of my Instagrams or not Besma specifically about Beloved. I know we're friends on Instagram. We're friends in real
Anyway.
life, too, but this product for lubrication is amazing. There's other great lubes too, and I'm not downplaying any of them. But the reason I'm kind of segueing to this one is because it gives you that same kind of, nice draw that you get with your normal lubrication when you're aroused. And there was a lube on the market years ago when I was in med school that did the same thing. They took it off. But now finding this again, it's like I found Holy Grail.
Like, it's it. It's it. That's what it is.
That stuff stays with me. But anyway, um, having someone talk to you about finding good things that are gonna actually help and not giving just um, like side advice. Actually, let's get into the detail and talk about
Yep.
what's out there that's going to make it better for you. What's out there that's going to improve your life? Because that's what we're really talking about. Good sex is great. Having conditions managed is great, but also just overall increase in satisfaction for life. That's what we're really talking about
Yeah,
here.
exactly. So again, and that goes back to what I was talking about at the beginning, is we need to reframe the way we think about it, right? So many times I would see patients coming to my office and maybe I was the fourth or the fifth, fourth or fifth stop.
Mhm.
Um, they'd seen a dermatologist, they'd seen an endocrinologist, and they're seeing all these different people. And finally getting to me, and I'm able to sort of put things all together. And sometimes they're on medications that actually conflict with each other, and like nobody's really seeing the problem or the person for that matter as a
Mhm.
whole, right? And so kind of putting it all together. And that's what I'm trying to do. And that's not to say that I love my dermatology colleagues, and I love my reproductive endocrinology colleagues, and all these different folks that we need to work with like as a team. And so having those people, right? If you have PCOS and pregnancy is what you desire, and the other changes haven't resulted in pregnancy or predicted, like a predictable ovulation, then you need to see your reproductive
Mhm.
endocrinologist. So it's
Mhm.
not like a promise that you're gonna not you're gonna not need to see all these other incredible specialists, but it's that you have somebody that understands the disease that can help guide you, along the path, not just for this one particular problem, but for life, so that
Yeah.
so that you really can improve your life, and to know what to expect, and to know what the pitfalls are, um, in pregnancy, in the perimenopausal transition, and all of these things. And how are we reducing health risks, right? How
Mhm.
are we reducing your risk of diabetes? About 50% of people, like today, the statistic is if you're diagnosed with PCOS, you have a 50% chance of developing type 2 diabetes in your 40s.
Mhm.
Right? Like that's staggering. That's a staggering statistic. And what I used, and that doesn't mean we want to be moving that needle, right? If
Mhm.
you get diabetes in your 70s, like okay, you're 70, you're gonna, you're the effects of that are not gonna be additive, because we're pushing that down the
Yeah.
road. So like we've bought you so many more years of health. But if you develop diabetes at age 40,
Yeah.
right? The health impacts for the rest of your, hopefully long life. But we want you to be not just living long, you want to be living long and well,
Yeah.
right? And so
Yeah.
all of that starts now, right?
Yeah.
It starts, and so we don't want to be waiting. And
Yeah.
so I think that that's really important. Some people
Yeah.
are like, nobody told me, I had no idea, and that's a shame, because these are things that we know, right? There was a survey of people with PCOS and their satisfaction of the care that they receive. There's like an average, like 2-year delay in diagnosis. It's
Yeah.
not that hard, right? The criteria are pretty clear. It's just, so I don't know. I don't know what it is. People aren't taking the time. The information is not getting out to the people that need to be, that are seeing these folks out there. I don't know. But that's too long.
Well, the good thing is we have physicians like you that care, physicians that like you that are trailblazers and creating um, their own map to meet the demand and the need that's there. As we're wrapping up, if I could ask you one last question, for that woman, for that person with ovaries that's out there that has just recently been diagnosed and doesn't know next steps, what would be the 2 to 3 things that you would tell them?
Okay. So if we're talking about you're just diagnosed, you don't really know what to do next. You need to make sure that you're, working on your nutrition. And 75 to 95% of people with polycystic ovarian syndrome have insulin resistance. So that means looking at what you're eating and reducing the amount of refined carbohydrates and sugars, improving fiber intake. That's really, really important. So getting, some good nutrition advice. Find somebody that can help you there. And um, two, like if you don't know how to cook, you need to learn some cooking skills, because one of the ways to better nutrition, if you are dependent on eating what somebody else made for you, you will never be able to get a handle on your health.
Mm.
Okay. And then the third thing is you need to know what your health risks are. So if you're somebody who has PCOS and, for example, you have really, really irregular periods or really delayed menses, you have to understand what the implications of that are. So you have to understand that that means you may have difficulty getting pregnant. You want to be on top of that. But it also means if there's a lot of backlash against hormonal contraception. But for some people, at least in the short term, they need to understand that if they are not ovulating, that puts them at risk for endometrial cancer, which is a type of uterine cancer. And so sometimes we need to, until we get it under control, we need to get you on some sort of treatment so you're getting progesterone to balance out, the excess testosterone and estrogen that your body's being exposed to. So those are like the three sort of like big things that I want people to take home. But like you said, we haven't even gotten into the nutrition. I think I'm going to have to come back and we're going to talk about that another time.
And we definitely have to, because again, it is a very, it's a topic that has a lot of avenues that we can dive into. And I do want to talk about the nutrition specifically. So I'd love to have you back to talk about that. Because again, that's a big question. What can I make in a meal plan for myself on a day to day that's not only going to help my PCOS, but keep me satisfied with
Yep.
what I'm taking in. So
Yeah, without feeling deprived.
yeah. Dr. Faris, thank you so much for joining us on
Thank
our
you,
first
Dr.
episode,
Ojo.
Climax After Dark. Join us again. Our second episode will have up the topic on our socials, what we're going to talk about next. I really appreciate you for tuning in. Until next time, thank you. Climax After Dark.
Good night, everybody.
Good night.